Hello friends, you are watching Nuyousmiles and I am back with another video on pharmacology. Today we are going to have fun with chloramphenicol. But before we begin, please subscribe to the channel and hit the bell icon so that you never miss a video from me. So let's get started. Here you can see examples for bacteriostatic and bactericidal drugs. And the chloramphenicol, which we will discuss today, belongs to bacteriostatic drugs. Other examples are also important in MCQ point of view. Please go through it. Let's discuss chloramphenicol in detail. It is initially obtained from Streptomyces venezuela in 1947. It is a yellowish white crystalline solid. It needs protection from lights, hence stored in dark colored bottles. Nitromycin moiety is responsible for the antibacterial activity of chloramphenicol. It is intensely bitter in taste. This is the chemical structure of chloramphenicol with nitrobenzene ring. Okay, let's discuss the mechanism of action. Chloramphenicol binds to 50S ribosomal subunit at the peptidyl transferase site and inhibit transpeptidation reaction. Please listen carefully. Chloramphenicol which bind to the P site, that is peptidyl transferase site, and inhibit the transpeptidation reaction, that is peptide chain elongation at the 50S ribosome. Okay. In the case of tetracycline, which is also broad spectrum antibiotics, tetracycline bind to the A site of 30S ribosome and inhibit the peptide chain elongation, inhibit protein synthesis and bacteriostatic effect. High levels may inhibit mitochondrial protein synthesis, producing bone marrow toxicity. It is a very important side effect of chloramphenicol. Let's discuss the antimicrobial spectrum. It belongs to broad spectrum antibiotics and bacteriostatic effect. Similar to tetracycline, it acts against gram-positive and negative cocci and bacilli, rickettsia, chlamydia and mycoplasma. Difference between these two are, that is tetracycline and chloramphenicol in action mechanism of antimicrobial spectrum. That is, it is highly effective. That is, chloramphenicol, it is highly active against salmonella, including salmonella typhi. It is more active than tetracycline against Haemophilus influenzae, Bacillus pertussis, Klebsiella and anaerobes, including Bacteria fragilis. It is less active against gram-positive cocci, spirochetes and certain enterobacteria and chlamydia. Entamoeba and plasmodia are not inhibited. Like tetracycline, it is ineffective against mycobacteria, pseudomonas and many proteases, viruses and fungi. Coming to resistance, chloramphenicol resistant salmonella typhi have emerged due to the transfer of R factor by conjugation. Resistance among gram-negative bacteria is due to acquisition of R plasmid encoded for an acetyl transferase, an enzyme which inactivates chloramphenicol. Decreased permeability into the resistant bacterial cell and lowered affinity of bacterial ribosome for chloramphenicol are other mechanisms of resistance. On to the pharmacokinetics. Chloramphenicol is rapidly and completely absorbed after oral ingestion and it is 50 to 60% bound to plasma proteins, freely penetrate serous cavities and BBB, that is blood-brain barrier. It crosses placenta and secreted in bile and milk. Chloramphenicol is primarily conjugated with the glucuronic acid in the liver and is little excreted unchanged in urine. Cirrhotic, that is liver cirrhosis patient and neonates who have low conjugating ability require lower doses of chloramphenicol. The metabolite is excreted mainly in urine. Coming to administration, administered orally as capsule, 250 to 500 mg 6 hourly for adult and for child it is 25 to 50 mg per kilogram per day. Topical application on eye or ear is also recommended. Adverse effect, which is very important in MCQ point of view for NEET MDS aspirants. So listen carefully. First one is bone marrow depression, which causes aplastic anemia, agranulocytosis, and thrombocytopenia, together known as pancytopenia. Hypersensitivity reactions, including rashes, fever, atopic glossitis, and angioedema. Irritative effect like nausea, vomiting, diarrhea, pain on injection. Superinfection, which is similar to tetracycline but it is less common. Grey baby syndrome. It occurs when high doses were given prophylactically to neonates. A nation-grade cyanosis develops, followed by cardiovascular collapse and death. It occurs because of inability of the newborn to adequately metabolize and excrete the chloramphenicol. Okay, moving to the interactions. Chloramphenicol inhibit warfarin, cyclophosphamide, and phenytoin metabolism. Phenobarbital, rifampin, and phenytoin enhances the chloramphenicol metabolism, therefore reduces the concentration. Failure of therapy may occur. Erythromycin, clindamycin, and chloramphenicol can exhibit mutual antagonism of antibacterial action, probably due to proximity of their binding site on bacterial 50S ribosome. Okay, then coming to uses. H. influenza meningitis. Chloramphenicol has excellent penetrating ability into the CSF and is highly efficacious, but third generation cephalosporins are mostly used now. Second one is anaerobic infections caused by Bacteroides fragilis. Clindamycin or metronidazole are preferred for this. Intraocular infections. Chloramphenicol is preferred drug for endophthalmitis caused by sensitive bacteria because it attains high concentration in ocular fluid. Next one is typhoid fever. Chloramphenicol was the drug of choice but not used now due to the spread of resistant Salmonella typhi. Topically used in conjunctivitis and otitis extrema. Second line drug in brucellosis, cholera, rickettsia, chlamydial infection and whooping cough and UTI, that is urinary tract infection. So guys, let's wind up this topic. I hope this video is useful for you. Continue watching. Keep me in the loop. Thank you.